Good afternoon, everybody. I'm Sunir Garg. It's my pleasure to be able to moderate the great debates. Thank you, Drs. Belodi and Bakri, for the kind invitation. We have fewer chairs than we do speakers for this session, so Dr. Pulido has graciously offered David Brown his lap. If we're going to be on the wings, I'll ask my colleagues, please be on the ready, because we have very short periods of time to do this. First, complement inhibitors, so ground rules. This is super critical. Not whose position you agree with, but who made the more convincing argument. That's the rules. Okay, complement inhibitors, my good friend and colleague, Dr. Anat Loewenstein.
Thank you very much, Dr. Belodi and the organizers, for allowing me to present the pro side of complement inhibition in this debate. That's not on my account of the time. That was not my slides.
Those are not your slides.
No. Okay. We count from now. So I just want to remind all of us that geographic atrophy is a blinding disease. And patients are expected to lose 6 to 10 letters, and in 2/3 of them, the ability to drive within 2 years. A big problem. New treatments do inhibit complement, which makes sense in view of the fact that complement is a key driver of AMD in general and geographic atrophy in particular, as has been shown by a plethora of histological, physiological, and most importantly, genetic data. Natural histories, as well as our clinical experience as retina specialists, has shown that geographic atrophy growth, as well as symptoms, do not correlate with visual acuity, like this patient who actually had a decrease in visual acuity only when the lesion became subfoveal. So both the FDA and us, the retina community, recognize that visual function is more than just visual acuity in GA. And probably novel endpoints are needed to show efficacy of GA treatment, be it tissue preservation, and potentially additional visual function tests. So for preservation of tissue, pegcetacoplan has been shown to lead to a meaningful reduction of GA growth in up to 42%, and the effect is increasing over time. Similarly, avacincaptad pegol led to a meaningful reduction in GA growth, both when dosed monthly and every other month. And this pivotal trial data is supported by post-approval data from Bascom Palmer showing a 40% reduction in GA growth over 1 year. And now to the function. Pegcetacoplan did delay progression to severe visual impairment with a 38% risk reduction over 2 years. Also, it was associated with a slower vision loss and, on the right side of the slide, better quality of life. Microperimetry, another functional parameter, showed the benefit of pegcetacoplan in a 3-year pre-specified endpoint, alluding that the tissue saved after pegcetacoplan treatment, which I showed you in the slides before, is functional, refuting theories about zombie cells of which you might hear soon. The risk-benefit is favorable. There is CNV, which is part of the natural history of GA, but it is accelerated to about 12%, but we can all know how to treat it. Look at these patients with bilateral subfoveal GA who participated in the OAKS trial. It's not difficult to see that the GA in his not-treated fellow eye grew 3 times more than the pegcetacoplan-treated eye. And, even if visual acuity is preserved, GA still causes a substantial visual function impairment. And if we can slow GA growth and continue to see our grandkids, as I would really like to do, we should. Thank you.
Next up, given the con argument, is Demetrios Vavvas. Welcome, Demetrios.
Thank you. They said that there is a code that you will see.
Oh, yes, the QR code.
Before that, conscientious and evidence-based. Thank you for the opportunity to speak on behalf of all. Will these new drugs improve my vision? No. In fact, all functions will decline. Will it prevent me from losing more vision? Actually, no. All functions trend worse with a drug, and you will feel so. Will it prevent me from getting wet AMD? No, 2 to 4 times more likely to get wet AMD. But they tell me we can treat AMD, wet AMD. Isn't it good and okay to get wet? 2 advanced stages of disease are worse than 1. And because many downplay the conversion to wet, here is simplified form, the data from Philly, Ox and Derby, worse vision despite treatment. Now they say after more post-hoc data analysis, they found functional benefits. Post-hoc breaks down randomization and balance of risk factors, thus hypothesis generating, thus not proof. And just some more details for fun. Here they mix treatment and no stats. Here they have no details, no vision. Here they show the nominal p-test. Nominal means not adjusted for multiplicity, means not significant. And on the bottom they have nothing. No numbers, no baseline characteristics, not statistically significant, not even nominal. I'm sure there must be risks. Yes, many and significant in number and severity. GA is a huge burden. A so-called treatment with no functional benefit imposes additional burden. Here, an alternative with similar level of evidence and efficacy, vitamins. It is health span, not lifespan that we should care. Don't keep alive the zombie RPE cells. I appreciate these honest answers. Surely all doctors advocate for conscience. Absolutely, including the smartest one of them, the silent majority, and the European Medicines Agency, based on lack of any real functional proven data, has denied multiple times. Focus on function, real proven function. Vote conscientiously. Thank you very much.
All righty, great job, speakers. I think there's supposed to be a QR code that's going to come up. If not, we will just cheer and wave our hands widely in the air. Oh, wow, this is going to take a long time unless you guys are already here. But we have 1 minute to do it, so please join me in voting for those outstanding things. Whoever gave the more compelling argument. I think Pellis and Estellas are going to invite Dr. Vavvas to be on their speakers bureau. I put mine on my home screen, but now I have to find it. I need a stronger ad of my glasses. Oh, this seems like it's getting close. Yeah, it's taking a little bit longer than I anticipated. Okay, well, that didn't work. So I'm just going to do it the old-fashioned way. So, oh, the con. Wow. Dr. Vavvas, crushing win. Well done. I would have thought it would have been much more controversial than that. Very good. All righty, next up is my friend and colleague at Wills Eye Hospital, Dr. Jose Pulido, he with the nice lap. His talk will be Fluorescein Angiography is still necessary in the initial management of wet AMD. Pro.
All right, thank you so much for the opportunity to talk today. This feels like dinosaurs versus robots. As opposed to my second colleague, I owe money for a patent to Mayo Clinic, so I don't make money on these things. Is fluorescein angiography extinct in the world of OCT and OCTA? Is this dinosaurs versus robots? I'm going to give you one case because of the short amount of time. 57-year-old gentleman sent in with the diagnosis of AMD. Here's the Optos wide fields, fundus autofluorescence on the other side, Optos wide field of the left eye, and OCT and OCTA, you can see the trees beautifully. So here's more beautiful images that you can see with your OCTA. The patient was injected and was injected 3 times and reevaluated in 4 months. But whoa, wait a minute, what's the fluorescein showing here? And then on higher up magnification, you see angioid streaks. And you look at the patient, you turn the lights on in the room and you look at the patient, and the patient has plucked chicken skin appearance. You send for genetic testing, and he had biallelic variants in ABCC6, so he has pseudoxanthoma elasticum. The patient can die from hemorrhages in the GI system and cardiovascular system, and you can save him. And there are genetic treatments being developed at this time for pseudoxanthoma elasticum. So fluorescein angiography gives you a different perspective. You see the forest. Inject alone or inject and save a life. Thank you.
Thank you, Dr. Pulido. Giving the con argument is Dr. David Brown. Welcome.
Thank you very much. Fluorescein angiography is not necessary for the initial AMD management. These are my disclosures. Most significant, Jose Pulido is a mentor of mine at Iowa, and he's almost always right. Your grandma comes in. She's being followed for dry AMD. She's got metamorphopsia, 20/50 vision, intraretinal cysts, or sub-RPE changes. Does she really need a dye injected into her systemic circulation? Goes to the eye, gives you these beautiful fluoresceins. Let's look at some of the things you ought to think about fluorescein angiography. What are the economics? Basically, Medicare allowable is $159, minus 50% overhead, minus $52.50 for the vial. You net $27.18. What about the safety? This big survey of ophthalmology review reveals up to 1 out of 6 have nausea, vomiting, itching, up to 1 out of 16 have hypotension, chest pain, dyspnea, anaphylaxis, MI seizure, 1 in 170 to 1 in 2,500. Dr. Yanutzi, big Macula Society and non-Macula Society member survey, found the severe complication rate of 1 in 1,900 and a death rate of 1 in about 250,000 people. So your grandma's here. Do you really need to risk her life for $27? So what does the literature say us on really needing this? This is our smart friends in Paris, including too soon departed Dr. Taglioni. And they looked at OCT versus FFA. And this wasn't OCTA. This is just regular OCT. And what they found out, sensitivity, specificity, no difference in OCT. These are our smart friends at Iowa. And they looked at, in a mass fashion, cases that had fluorescein angiogram, how would they decide what to do? And OCT, how would they decide what to do? And in no case did fluorescein angiography alter the initial clinical management of choroidal neovascular membrane. So again, your grandmother has obvious conversion to wet macular degeneration. What do you do? If it looks like a duck, it walks like a duck, it quacks like a duck, it's probably a duck. So you break out your anti-VEGF of choice. Fluid goes away, she's 20/25. Fluorescein angiography is not necessary for the initial management of wet age-related macular degeneration.
Thank you, Dave. All righty, so on the home page, when you go to the polling and then you click on the debates, which is toward the bottom, at the top of the listing time stage, there's interact with this session live. You push that one, and that's how you vote. And both the speakers would be congratulated for being done under their allotted time. Those were very pithy arguments that they made. That's rarely something that you hear at a retina meeting. Oh, the cons. This is a very conservative group. The cons have it. Dave Brown, FA is not needed. Well done, well done. Don't kill grandma. All right, next up from Canada is Rajeev Muni. He'll be talking about Pneumatic Retinopexy Pro. Welcome, Rajeev.
Thank you so much. Can we turn up the audio? We have some videos here. So I'm going to be talking about the Pro for Pneumatic Retinopexy. You just advance the slide. There we go. These are my financial disclosures. So today I'm going to convince you that simple retinal detachments with single superior breaks should be treated with pneumatic retinopexy. Paul Ternambi already showed us that visual acuity outcomes were better with pneumatic retinopexy compared to scleral buckle. We then did a randomized controlled trial comparing head-to-head pneumatic retinopexy versus vitrectomy with better functional outcomes, better ETDRS visual acuity at every time point. Vertical metamorphopsia, significantly worse with vitrectomy. We also showed for the first time with an external reading center that EZ and ELM discontinuity was worse with vitrectomy compared to pneumatic. Subsequent studies showed high rates of retinal displacement with pars plana vitrectomy that was followed up with a prospective clinical trial demonstrating the same thing, and that vitrectomy patients had worse anisoconia. What about outer retinal folds? Another bad outcome after retinal detachment repair, worse with pars plana vitrectomy. Why does that happen? Well, in pneumatic, we know that we attach the retina in a slow and gradual manner, allowing the corrugations to resolve prior to retinal reattachment. If we can turn up the audio, please. Now, my colleague's going to talk to us about all the other techniques that we can use for retinal detachment repair. Now, vitrectomy, it's an efficient procedure. It's easy to do. But really, from a microstructural perspective, it's probably the most crude method of fixing a retinal detachment. Sure, it's attached, but it's attached in the wrong position. Clearly, we don't want that. What about scleral buckle? It's a tried and tested technique, but we know it's a bloody procedure. Do we really need to do this for simple, superior retinal detachments? Well, what about the reattachment rates with pneumatic for single superior breaks? There's a 2% difference between pneumatic and vit. That would mean you would have to treat 37 patients to save one patient from needing an additional procedure. All the while, regardless of the complexity, visual acuity outcomes are always superior for pneumatic retinopexy. Audio up, please.
Du, hier vorne. Was ist dein Handwerk?
Ich bin Töpfer, Herr.
Und du, Arcadia? Was ist dein Handwerk?
Herr, ich bin Bildhauer.
Ah, Bildhauer. Und du?
Ich bin Schmied, Herr.
Spartiaten! Was ist euer Handwerk?
Why subject your patients to worse outcomes for a procedure that just because it's more efficient? Don't forget the cataracts and all the other complications that can occur. Thank you very much.
Thank you, Rajeev. Giving the counter argument is Dr. Michael Altaweel. Hey, Michael, nice to see you.
I have no video. Yeah, sorry.
You can do a dramatic reenactment for us if you'd like.
Yeah. All right. So my job is to convince you that vitrectomy and scleral buckle are still the favored choices. And really, the PIVOT trial is great, and I just want to show you what happens in real life. These are the inclusion and exclusion in the PIVOT trial, so Dr. Muni's study. So you can see that pneumatic retinopexy was done for mostly superior tears. You could be phakic or pseudophakic, but if you had grade B PVR or inferior tears or tears posterior to the equator, then those were excluded. And we've long known that relative contraindications are chronic RD because the fluid may not absorb, being pseudophakic, or vitreous hemorrhage where you have limited view. The PIVOT trials results came out in 2019. In 2020, we underwent the beginning of the COVID pandemic. And that's where I think that practice really changed. Particularly, we noticed it in our institution. We started doing a lot more pneumatics because we had access difficulty to the operating room. But people have really expanded beyond the PIVOT criteria, and this has led to a decrease in success rates. We also know that some of the decisions we make are based on convenience. They are done twice as much during the weekend as you might do on a Wednesday or a Thursday because you have better access at that time. This is an example of a patient who had a bubble and went through a large tear and is now subretinal and has caused Macula-Off detachment. So the techniques may differ from the PIVOT method. In our hands, we find that it's actually much more interruptive of clinic to be doing a pneumatic in the way that it was done in PIVOT. It takes a lot of time, and it's good for some cases, but not for all. It takes a while to assure that your patient has done well, and up to 40% in the IRIS registry actually come to needing that second surgery. This is an example of a patient 3 days after pneumatic, and it just shows at 7 days they were well, but now they have an inferior detachment. When we look at a meta-analysis of 11,000 patients, the rate of developing a second tear in a person who's had pneumatic is 27%, whereas in vitrectomy it was 0. And the success rates were 91% for vitrectomy versus 69% for pneumatic. So Dr. Muni has advocated about a better detachment result or attachment when you do a pneumatic. This is a picture of a patient I saw just earlier this week who had a pneumatic, and this is 6 months afterwards. And from the PIVOT trial, we'll take again, they show you the vertical metamorphopsia, but when it comes to horizontal metamorphopsia, it's actually quite high in both and statistically the same. And there was a little bit more in vitrectomy. We also know you can get more retinal folds, as he's shown, but also by 6 months, they become equal and low. The iris registry is really the most important. This was done, first study 2020 came out, and now lately for OMIC, there's been a new analysis that includes 13,000 patients, and the success rate overall is 59.82%. And it's shown now that if you are pseudophakic, that was 54%. If you're phakic, it's 64%. So in conclusion, the success rates for us doing pneumatic around the country does not equal what was found in the PIVOT trial. There's really a high rate of metamorphopsia for both procedures. Pneumatic retinopexy is certainly appropriate in the right conditions, but I feel that we have expanded those conditions that we do it for, and vitrectomy and scleral buckle remain the optimal first choice for the repair of most detachments. Thank you.
All right, thank you guys. Okay. Whoa. It was not a high integrity win for Dr. Altaweel, but a win nonetheless. All right, next up, Macula-Off retinal detachment surgery. Earlier surgery is better. The pro argument will be by Dr. Tarek Hassan.
Thank you, Sunir. These are my financial disclosures. None are relevant for this debate. So it's obvious that early macula-off retinal detachment repair is better. And when you're arguing the obvious, you must defend against the absurd for my opponent. And that will be based in formal techniques of science denial, like the Flat Earth Society and other things that he subscribes to. But we know that cons will only dance and juggle the truth, because surgeon schedules, long weekends, theater, big game tickets should not be of primary concern to the patient that's lost vision. But the con argument is going to try to divert with some sleight of hand, tell you about macula-off detachments and fovea-off detachments are different. Repairs can be done after a long time, or it's the same after scleral buckle or vitrectomy. Common sense demonstrates the value of early RD repair. Fovea-off detachments you want to fix quickly, because how do you know how long a macula has been detached? They show up at all different times. Their symptoms are variable, and their histories are somewhat unknown to the patients often. Macula splitting RDs, of course, you want to prevent further vision loss. And macula sparing or fovea sparing detachments you want to fix because you don't want to have further vision loss. And we know that vision loss and progression of RDs are correlated to head and eye movement in some very nice papers. And delaying surgery would require strict bed rest and patching, completely impractical. Science demonstrates the value of early RD repair, and the definition of early matters. And since I'm talking first, early is 3 days or less. Experimental models in human patient histology have shown that photoreceptor cell death is induced as early as 12 hours and peaks 2 to 3 days after detachments. And these pathophysiology and biochemistry and histology are increasingly described as potential treatments. The old literature shows that macula-off detachments can be repaired in 7 to 10 days. But these were all done in scleral buckle repairs, and we know that residual subretinal fluid is in 50 to more than 90% of scleral buckle repaired macula-off detachments. So basically, the duration of macular detachment is equivalent in the early and late groups. And of course, comparative scleral buckle studies showed that there's no difference in outcomes. Modern day vitrectomy flattens the retina sooner and clearly shows in all of these recent studies that repair done within 3 days gives you better results if it's done with vitrectomy. He may bring up the fact that I actually published a paper 20 years ago saying that you could fix a macula-off detachment within 10 days. But of course, we were a lot younger, and my own findings don't apply anymore because everybody does vitrectomy. These studies, which show that 0 to 3 days or even 0 to 2 days have better visual acuity improvements than longer. These are done predominantly with vitrectomy and are real. And lastly, early RD repair prevents PVR. And all of these studies show that you have microglial and astrocytic proliferation that starts as early as 1 day after detachment. And this picture should sell you right here from Lewis that shows the normal retina. 1 day after detachment, you see microglial proliferation. 3 days after RD, look at the macrophage and microglial proliferation. So everything is obviously pointing to the fact that early detachment is better than, early repair is better than late repair. 25 years ago, we could have had a competitive debate. Now, Carl is just going to try to juggle the facts. But clearly, he's a good debater, we'll see. Definitely a very good juggler, but no matter what he says, even the O's can tell you who the winner is. Thank you.
Well done. Next will be Dr. Carl O, who will be talking about the cons. And Dr. O is no longer wearing his dad khakis, so that is outstanding.
Yes. All right, well, here's the question. Earlier surgery is better. Con. I have no relevant disclosures. And when I got this assigned topic and opponent, the esteemed Dr. Hassan, I knew that I was in for a challenge. I've spent lots of time with Tarek over the years, many of those listening to his fantastic podium presentations, so I could make this next slide in advance. I knew that I would agree with much of what Tarek has said. But there are important reasons that we must not vote that earlier surgery is better for macula-off retinal detachments. First, earlier than what? Early is defined as before the usual or expected time. And there is no usual or expected time that applies to surgery for all macula-off retinal detachments. There are dozens of papers on the timing of surgery for retinal detachment with no consensus on optimal timing. The optimal timing for each patient can be quite different, and we're still learning how to predict outcomes. OCT can show us patients who might benefit from more emergent surgery, but it can also show us patients for whom timing of surgery will have little bearing on prognosis. But here's what's most important. We should not make statements that could come back to haunt us, okay? So imagine that you have repaired this macula-off retinal detachment and you've achieved a beautiful anatomic repair. If the post-op vision is excellent, no one will ever ask if the surgery should have been done earlier. The question of whether surgery should have been done earlier arises only when the outcome is disappointing. And who asks that question? The patient and the lawyers. All right. And did you know that professional society guidelines, videos, and presentations at major medical meetings like this may be considered authoritative in a legal action? So now, imagine yourself being deposed at the complaint of this patient. Doctor, were you present at the 2024 AAO Retina Subspecialty Day debate on the timing of surgery for retinal detachments? Yes. Doctor, do you recall the audience response? Yes. Doctor, how did you vote? And remember, you're under oath. These lawyers want the truth, and you have to give them the truth. So public pronouncements carry consequences. Let us agree that macula-off retinal detachments should be repaired at the appropriate time, which should be determined by each surgeon and patient. Earlier surgery is not better. Thank you.
All right, well done, guys.
I think I want Dr. O as my lawyer.
Yeah.
If I ever get in that situation.
Whoa, a crushing win for Dr. O.
All right, so I just want to clarify.
This is John Kitchen, so we'll be talking about conservative management of floaters, so let them suffer.
All right, thanks, Sunir. So I just want to clarify, I think there might be something wrong in the program. I am pro-vitrectomy for floaters. It's the most common surgery that I do actually at this point. So I'm going to be taking the pro stance. Dr. Blinder will be taking the con stance as far as that goes. So my disclosures can be seen in the outline, but I do remove symptomatic vitreous opacities at a pretty high rate relative to other surgeries. So I want to point out two main things. First of all, these are two amazing papers. These are treatises on vitreous and everything you may need to know about vitreous and then the impact it has on vision. Definitely go. They're worth buying these papers. I bought both of them myself. The second, I want to introduce you to Weissy. And he's a wise guy. He's a Weiss ring, and he's going to bring us some pertinent wisdom throughout my talk, and his mortal enemy is the vitrector. So why do we do vitrectomies for symptomatic vitreous opacities? Well, first of all, floaters bother patients. Vitrectomy surgery is safe, and it's very effective. So let's look at this. Now, I know Dr. Blinder is going to say, why would you ever operate on a good seeing eye? Well, it's not about the visual acuity. We have multiple papers that show there's a significant decrease in contrast sensitivity in patients who have symptomatic vitreous opacities, and that this can actually improve after vitrectomy. Over a 50% decrease in contrast sensitivity. We don't measure that in our clinics. Myopes are more affected. It can even affect patients who have asteroid. So you want to be mindful of that. The second question, is there a cure? Absolutely, not just a treatment. This is a cure for our patients. When we remove vitreous opacities with vitrectomy, we have an increase in contrast sensitivity, increased in VFQ score. Patients are happy. In fact, this comes from the ASRS. It actually says that some patients have vitreous opacities severe enough to warrant surgery. If you look at the most recent PAT survey, 2/3 of doctors, vitreoretinal specialists, would say they would remove vitreous opacities in a phakic patient without a vitreous detachment. That's really aggressive in my mind, but 2/3 are saying that they would do this. What about the cost? Well, actually, vitrectomy for vitreous opacities is one of the most cost-effective surgeries that we have as far as improvements in quality of life. We can see here it's very effective when we compare it to other therapies like cataract surgery, amblyopia therapy, and even retinal detachment therapy. We can see that it has a beneficial cost effectiveness for our patients. Lastly, is it safe? Is it something that we can do safely for our patients? We do know there's risk to any surgeries, risk of retinal tears, retinal detachment. You must always depress after the case to make sure you find all the breaks and treat all the breaks. But fortunately, the real complication we have to worry about is cataract formation. And eventually everyone will get cataract whether they have surgery or not. And in general, it does appear to be a very safe thing. When we look at the largest look back at vitrectomy surgeries for vitreous opacities, 17,000 cases in the Irish database, 2.6% went back for retinal detachment repair. So what I ask you to do in this election year is to choose freedom over fear and choose to eliminate bothersome floaters. Thank you very much.
Alrighty, thank you, John. So the conservative management, which is to sit on it, will be given by my good friend, colleague, Dr. Kevin Blinder.
And thank you, Senior Organizing Committee, for allowing me to speak today. I do want to, these are my financial disclosures. I do want to acknowledge that certainly John is a gifted, eloquent, entertaining speaker, but I have to disagree with him on this topic. So let's start at the beginning. Nomenclature, what are we talking about? We're talking about floaterectomies, right? No, we aren't really. We're talking about vitrectomy for removal of symptomatic vitreous opacities. We're taking out vitreous with floaters in it, not just the floaters. So that's an important point to notice. So back in the old days, we used to tell our patients, before you take the plunge, dive off the deep end, come to me and I'll take out those pesky vitreous opacities. I think it's changed now. Our mentality's changed. There's new technology out there, small gauge sutureless vitrectomy, wide angle viewing systems. I think that that it is a safer procedure now, but it is not risk-free. Let's also remember time is on our side. Acute symptomatic posterior vitreous detachment does not remain symptomatic for long. Most of the time they resolve, patients come back and they thank you for not taking the aggressive approach of vitrectomy. So is the risk of surgery worth the potential benefits? That's really the question here. I think that the best data that we have, the largest patient series, are the Irish registry data, Rubino et al., 2020 Ophthalmology Retina, looked at over 17,000 eyes undergoing vitrectomy for vitreous opacities. 12.4% returned to the operating room for cataract extraction, which John pointed out. It is a treatable thing, but 3.7 returned to the operating room for other non-cataract procedures, and a whopping 2.6 returned for retinal detachment repair. Unacceptable rate, I think. New data just presented, Chan et al., ASRS in Stockholm, looked at over 42,000 eyes undergoing vitrectomy. They had a vitreous hemorrhage rate of 26.3%, extremely high, RD rate of 4.2%, and endophthalmitis rate of 3.7%, extremely high, a lot higher than I would have thought. So this is really a procedure that has risks to it. We have to tell our patients that, and it's not something that we want to do routinely for our patients. But if you have to do it, my rules for vitrectomy are: do a complete vitrectomy, confirm the hyaloid is actually elevated. If it isn't, do whatever you need, Kenalog, Blue G, elevate the hyaloid. If you don't do this, this is going to lead to recurrent vitreous opacities and very unhappy patients. Also, vitrectomy should be done by vitreoretinal surgeons who can deal with the complications. And of course, as John alluded to, sclerodepression at the end of the case, you want to take care of the tears and or detachments that you see intraoperatively. But again, this is a procedure with inherent risks. So how are you going to vote today? Well, in the PAT survey just 2 years ago, everyone voted that they really offer this to their patients very, very infrequently. I think it's how you put the question to the surgeons. So in conclusion, prima non nocere. First, do no harm. Second, I think you need to choose wisely. Most of the time, the risks outweigh the benefits. Thank you for your time.
All righty, thank you, Kevin. So that was our last debate of the day. A lot of work, a lot of experience, a lot of hard, thoughts go into this. Persistence is key. Oh, I would have thought it would have gone to Kitchens, but no. Despite the laughs, Dr. Blinder wins. Well done. Thank you. Thank you, everybody. Dr. Bellotti.
Thank you for that very engaging session and the whole afternoon. But now we have 30 minutes for a refreshment break. We're going to have some first-time results in clinical trials and late-breaking presentations. So please come back for the end of the afternoon session. Thank you.